Hi, in this presentation we will discuss about COPD and pharmacology of drugs used in COPD. COPD or chronic obstructive pulmonary disease. COPD is inflammatory disease of lungs with progressive emphysema, that means alveolar destruction, and bronchial fibrosis. There is loss of bronchial elasticity, which leads to closure of small airways during exhalation. Airway destruction, increasing part of which is irreversible and which is increased by exercise, causing shortness of breath. There is morning cough during winters, and it progresses to chronic form with intermittent exacerbation, and sputum becomes purulent. Exacerbation happens by infection, pollutants, and smoking. Stopping smoking slows progression. Smoking has been considered as main risk factor for COPD. Pulmonary hypertension is late complication which may lead to heart failure. Coming to drugs used in COPD, first class is bronchodilators, which prevent closure of peripheral airways during exhalation and give symptomatic relief in COPD patients. Under bronchodilators, you have sympathomimetics, which are adrenergic beta 2 agonists. These drugs they stimulate beta 2 receptor in lungs and airways and thereby produces bronchodilation and gives symptomatic relief. Under sympathomimetics, you have short-acting beta agonists and long-acting beta agonists. Short-acting beta agonists include salbutamol and terbutaline, and long-acting beta agonists are salmeterol and formoterol. Next bronchodilator category is methylxanthines, and under this category, theophylline is mainly used in COPD. Anticholinergics, which are muscarinic M3 receptor antagonists. In this category, you have ipratropium bromide and tiotropium bromide. Doxapram, which is respiratory and CNS stimulant. It is also used extensively in COPD patients. Next class is leukotriene antagonists. They antagonize the action of leukotriene on leukotriene receptor LT1 receptors and includes montelukast and jafelukast. Next category is PDE4 or phosphodiesterase 4 inhibitors, and in this category there is roflumilast, which have anti-inflammatory action. Next category is corticosteroids, which are mainly anti-inflammatory. Two categories: systemic corticosteroids includes hydrocortisone, which is given intravenously, prednisolone, which is given orally. Inhalational corticosteroids includes beclomethasone dipropionate, budesonide, fluticasone propionate, flunisolide, cyclesonide, and mometasone. These are all given by inhalation. Next category is antibiotics against H. influenza, and example is cefuroxime, because infection is quite commonly seen in COPD patient. That's why antibiotic treatment covering H. influenza is also required. And there is also recommendation for vaccination against influenza and pneumococcus in COPD patients. And most commonly used is oxygen therapy. If drugs are not able to control the condition, then ultimately oxygen therapy is given to the patient. Sympathomimetics, these are beta 2 receptor agonists. They stimulate beta 2 receptor on bronchial smooth muscle, produces bronchodilation, decrease inflammatory mediator release. Two categories: short acting beta agonists include salbutamol and terbutaline, both given orally as well as by inhalation. Long acting beta agonists include salmeterol and formoterol. Salmeterol is having slow onset of action, which is mainly given by inhalation, and formoterol is having fast onset of action, which is also given by inhalation. Next category is methylxanthines. They relax bronchial smooth muscles, increase mucociliary clearance, stimulate respiration, decrease histamine and other mediator release. They are also having mild diuretic action. They also increase metabolism, stimulate heart rate and force of contraction, and because of these actions, they may have side effects when used in asthma or COPD. Mechanism of action of methylxanthines include the increase calcium release in cardiac and smooth muscles. Second is inhibition of phosphodiastasis, which increase cyclic EMP and produce bronchodilation. And third mechanism is blocking of adenosine receptors. Adenosine produces bronchoconstriction. So by preventing action of adenosine, by blocking adenosine receptors, these drugs they prevent the bronchoconstriction. Theophylline is mainly used in COPD. Doxyphylline is also available, which is long acting and without interference with sleep. Next category is anticholinergics. These are muscarinic M3 receptor antagonists. They bind to M3 receptors in airways and prevent the action of acetylcholine. Acetylcholine is bronchoconstrictor, and by preventing binding of acetylcholine to M3 receptors, these drugs prevent the bronchoconstriction. Drugs include ipratropium bromide and tiotropium bromide. Ipratropium bromide is short acting with action of duration of action is 4 to 6 hours, and tiotropium bromide is long acting with 24-hour duration of action. Next category is leukotriene antagonists. These drugs they antagonize the effect of leukotriene on leukotriene 1 receptors. Leukotriene produces bronchoconstriction, and leukotriene 1 receptor antagonist they prevent the action of leukotriene on leukotriene receptors and thereby prevent bronchoconstriction. They produce bronchodilation, decrease sputum eosinophil count, decrease bronchial inflammation, decrease mucus, decrease hyperactivity of bronchial muscles. Examples are montelukast and jafilukas, both given orally. There is another drug called xylitol, which blocks synthesis of leukotrienes. So leukotriene is bronchoconstrictor, and this xylitol prevent the synthesis of leukotriene. So if there is less leukotriene, means there will be less bronchoconstriction. Next category is phosphodiesterase 4 inhibitors. And example include roflumilast, which is given orally with 79% viability. It is long-acting selective phosphodiesterase 4 inhibitor. It increases the cyclic EMP. It is having anti-inflammatory action, decreases inflammatory mediators release. It is also having anti-emphysema action. That means help in prevention of alveolar destruction. It reduces the number of episodes and worsening of COPD. It is very commonly used drug in COPD. Common side effects include diarrhea, weight loss, loss of appetite, abdominal pain, headache, and dizziness. Next drug used in COPD is doxapram, which is a respiratory and CNS stimulant. It improves both rate and depth of ventilation. Also used in postoperative respiratory depression, apnea. It is given IV. Category of drugs used in COPD are corticosteroids. They decrease bronchial hyperactivity and decrease mucosal edema, decrease antigen antibody interaction, inflammatory response, decrease reaction to other stimuli also. They have anti-inflammatory action, improve airflow, decrease exacerbation, may influence airway remodeling, decrease progression of disease. They also increase beta 2 agonist responsiveness, because beta 2 agonists, they after some time the patient become tolerant to beta 2 agonists, and if beta 2 agonists are used with corticosteroids increase the responsiveness or effectiveness of beta 2 agonists. Drugs include hydrocortisone, which is given intravenously, prednisolone given orally. There are many drugs given by inhalation. These include beclomethasone, budesonide, fluticasone propionate, cyclesonide, and mometasone. That's all in this presentation. Thank you very much.